Do you have some tips for people to bring to other providers to kind of help them to understand, here's how to talk about this with my loved one?
If you tell my loved one that they've got bipolar, schizophrenia, etc., they're never going to come back. Anosognosia is really a profound inability to see what everyone around the person sees. When people have anosognosia, the whole idea of taking antipsychotic medication is horrible to them.
You want to present evidence to somebody, and it's like that's not what a delusion is. The belief isn't rooted in like them having made a determination based on evidence.
We don't win on the strength of our argument, on confrontation. We win on the strength of our relationship.
Well, hello, Dr. Amador. I'm very glad to be able to see you again today. And we're finally able to do a follow-up in another episode of Ask Dr. Amador. We've been having a number of questions that have been coming in. So we've got several in the hopper. So I am going to jump in with a first question. It's a question from Beverly. And the question is, can withholding financial support be an effective tactic to ensure medication compliance?
I've seen that work many, many times. With my brother Henry, it's exactly what I did. That said, I very strongly feel that we need to provide food and shelter, a place to live, and the ability to eat and be healthy. But beyond that, if our loved one is asking for money for other things, I leveraged my brother with that. He wanted $5 a day for pocket money, and we went back and forth about it for 6 months. But how you leverage it really matters. So doing it with kindness, doing it with compassion, doing it with an apology. And what I used to say to him was, I'm really sorry. I know you're right. I make, a great deal more money than you get. And I did a little bit of LEAP with him. This is when LEAP was just starting out. I should really just give it to you. I understand that, but I'm not comfortable unless you accept the long-acting injections. And it took 6 months of going back and forth, but then he accepted it and stayed on it for the rest of his life. So I've seen many families that I've worked with also leverage using money, but it's how you do it.
Mm-hmm.
It's you're carrying a big stick, so you can speak very, very softly with apology and with empathy.
Yeah, I think families feel like they feel a sort of ickiness about doing that, about using that as leverage. But so, I mean, I definitely think it's helpful, and you probably would agree that like if you can keep the heat out of the conversation and just keep it as an open dialogue, that's the easiest way to do it. But I certainly understand why family members are like they feel a little strange about that. But then at the same time, if it ultimately is something that can strengthen your relationship with your loved one and kind of persuade them that like, hey, we're working on this together. It's something that might not feel as awkward.
Yeah, although it doesn't end up in many cases that I've seen with the feeling that we're working on this together. It does sometimes end up with negative feelings, like I can't believe you're making me do this. And the way to approach that, and certainly with the LEAP approach, is to be empathic, to understand your loved one's hurt and their feeling of maybe even a betrayal or being pushed around, and just be empathic. And then that tends to heal those hurt feelings, heal those wounds by being empathic and understanding and validating their experience and apologizing. I'm sorry that I'm doing this. I wish I didn't feel the need, but I do.
Yeah, I do think that part of the reason it's awkward from the perspective of family members is that it sort of triggers this guilt response that you have about just having more and being more financially stable and being in a position that they are not in and feeling like that's somehow your fault. I think that's challenging, but it's also, if it ultimately is something that can lead to somebody being in a better situation, it's worth using as a tool, but I understand the awkwardness of it for people.
Yeah.
So I'm going to move on to our first question about anosognosia. This is a question from Joanne. Question is there a role for video playback, and that's in quotes, as a teaching / coping tool / medication compliance tactic for people who have anosognosia to help them see / understand their illness, which showing them when they are not in active psychosis and with the support of a qualified mental health professional, how they are speaking and behaving when in active psychosis help them to see their illness in a way that they might not otherwise be able to do.
I had great hopes that this would work. And so I consulted on a project, and a summary of that project is in the first edition of I'm Not Sick, I Don't Need Help. And I just thought if somebody sees themselves talking to the voices, delusional, talking about delusions, and now they're stable, and they look back on that's going to increase insight. Didn't work. There's other research that's relevant in some people with tardive dyskinesia especially from the first generation antipsychotics. So they have abnormal involuntary movement disorder. Same thing has happened where there was video playback and people still couldn't understand in a sustained way that they had an abnormal involuntary movement, even though they're looking at the video of their hands moving or their perioral grimacing or the neck moving. So anosognosia is really a profound inability to see what everyone around the person sees. So short answer is no.
I know that like part of the way that anosognosia was discovered initially is with things like people couldn't see that they couldn't move an arm or
leg.
Something that, you know, should be visually pretty obvious. So it's like, it is definitely, I mean, to me, that kind of gets at the idea that you're trying to you want to present evidence to somebody. And it's like, that's not what a delusion is. There's no level of evidence that is going to persuade them of that's just like the belief isn't rooted in like them having made a determination based on evidence.
Right. And instead of learning in that study that I mentioned, we had patients confabulate and say things like, that's not me, you've doctored the video.
Yeah.
So getting the evidence, it's just because when you have anosognosia, your self-construct, your understanding of who you are is stranded in the time before you became ill. So this can't possibly be me was the response we were getting from our subjects.
Yeah. And I would imagine that's even more complicated in these days with deep fakes and being able to generate with AI.
Okay, good point.
I would imagine that that's going to be even more of a problem for people because they'll have more basis to feel that things might not be real that they're looking at.
Right. So I don't encourage it. And I have families that I work with that ask, should I just videotape him? Should I just videotape her? I always say, don't do it.
Yeah. What I can recall is like having asked my sister to listen to voicemails that she left. And it never went well. I mean, because she felt confronted, she got very angry. It really didn't matter what she was hearing because the confrontation was just making her so emotional that it wasn't really worth trying to do. But I definitely see why the idea would be, well, like, can't I just show you? And then won't, like, shouldn't you be able to get to this next step?
And what you're describing and what we're talking about really emphasizes that we don't win on the strength of our argument, on evidence, on education, on confrontation. We win on the strength of our relationship.
Yeah.
That's when we win the possibility of persuading the person to accept treatment.
I think it can be hard to let go of the idea that you want to convince the person that you're correct and you want them to admit that you're correct. And then if you step back and you think about that, it's like, that doesn't even work with people generally. I mean, like people who are not experiencing perception issues or people who, like in our politics, great idea. So I mean, it's like if you're really just trying to get somebody to admit that they were wrong and you were right, that doesn't even really work with almost anyone, let alone with somebody who has, really is really not perceiving things the same way that you are.
Yeah. And there's a saying I have, Lisa, that I try to live by, which is, Javier, do you want to be right or you want to be happy?
Yeah, exactly. I think we could all take that advice more often, although it can be, I mean, I understand it can be maddening if somebody's like, I never said that to you. And you really do wish that you could play it back. But it's like, well, what are you gaining by doing that? I mean, if it's upsetting the other person and it's not actually resolving anything, then, that's not your goal should probably to figure out how to move past it, figure out how to do workarounds that'll work for everyone. All right. Second question I've got on the subject of anosognosia is from Jackie. Question is, do people who are suffering from delusions and psychosis remember what they say and do while in active psychosis or the delusional state? So it's kind of similar to what we were talking about, but also kind of a separate inquiry.
It is separate. And we've done research on this and it's spotty. Some people will remember what they've said in their delusional states and will say, I can't believe I thought that. And, of course, that's not true. And others will have no memory of it whatsoever. A lot of the research that we did when I was at Columbia University with people with schizophrenia primarily, we found that lots of deficits in awareness of not only delusions, but of things they had done, like aggressive, angry outbursts and things. Just no memory of it whatsoever.
I certainly have had acquaintances that were bipolar, and it just seemed like maybe they're in their mania, their brain is just
Yeah,
functioning too quickly
fog.
to make.
I call it the fog of psychosis and mania. It's
Yeah.
fog. It's like a fog, and so you're not encoding the memory.
And I don't, this might be anecdotal, but it does kind of seem like there are some things that are almost like state dependent memory that, you
Yeah.
learn about as an undergrad in psychology, that it's like, oh, well, if I remember something, like I might be more likely to remember something if I have a couple of beers because I had a couple of beers at the time that I did something. And
When I
it
learned
is
it,
sort of,
yeah.
I have noticed that, there are some things that people seem to remember when they're just in that, like if they're deteriorating and they start talking about things that's like, oh, I haven't heard you talk about that for quite a while. That's a concern. All right. So our next question on anosognosia is from Shelley. Is anosognosia a permanent condition? Is it possible that the anosognosia condition will reverse?
Great question. And the majority of people with anosognosia for their serious mental illness, it tends to be permanent. But there's roughly about 15% of people and this is from research, not from my, anecdotal observations, about 15% can develop awareness. The anosognosia remits. So for the majority, you should sort of make the assumption that if this has been going on for years, that it's likely going to continue. When you see improvements in anosognosia, it's usually in the first year. And again, that's a minority. It's a very small number.
Do you think of it as being like a light switch where you're like, you either have it or you don't have it, or is it sort of like there's degrees of it and people sort of go
It's
in
a
and out
dimmer.
of different phases?
It's a dimmer
Okay.
switch. And you can have a little bit of awareness and then you lose it. You can have a lot of awareness and then you lose it. When somebody has that stable, permanent anosognosia, we'll see some variations, over the course of the illness. And people get really happy when they hear that, oh yeah, I understand I was not behaving correctly, or I was behaving strangely when I was not taking medication. And now I get it. And everybody gets excited, like they've got insight. And the next day they're like, no, I don't think that's true. So there's minor fluctuations, like with any symptom of any brain disorder.
Mm-hmm.
If I had Parkinson's disease, one day my hands maybe be like this. Another day they could be like this. Symptoms wax and wane.
Yeah.
It's the same thing with the thought process in people with SMI.
So like a related question I've got about anosognosia is that, would you say that it applies to like things that are they're about insight, but it isn't necessarily awareness of your illness? So, something that I've always kind of wondered, is this anosognosia or not? For my sister, she really has never denied that she has the diagnosis that she has, but the insight that sort of waxes and wanes for her is being able to perceive whether or not her medication is actually effective. Is the insight that people like wax and wane on, is it always about whether or not they have the illness, or is it about how they perceive it?
There's pockets of awareness and unawareness, and we've done a lot of research on this, and others have replicated our research. So you can have people who are aware how medication has helped them, but they're unaware of the diagnosis and unaware of the symptoms. You can have people who are aware of the diagnosis, but completely unaware of how medication has reduced symptoms. So you see, and this is the nature of anosognosia in neurological disorders as well, you see pockets of awareness and unawareness. In neurological disorders, you can have patients, and I've evaluated someone like this, who is aware of the paralysis in his left leg, but unaware of the paralysis in his left arm. So you see pockets of awareness and unawareness.
So what do you tell people, like when you encounter family members who, say they've got a loved one who has kind of consistently really had like, what we think of as like blanket anosognosia. They just really don't believe that the illness, they don't perceive it, they don't see that the symptoms that other people see are there.
Or that treatment has helped.
Yeah. Right. So how do you kind of start that journey with the family and with the patient to kind of, apart from, the LEAP techniques, how do you kind of persuade them to start down the LEAP road?
By having a conversation, by opening up with you. And a lot of times we run into people who just stop talking. So that's the first step, is to open that closed door. And that usually involves apologizing for things like, I did this with my brother. I called him up and I apologized for telling him he was mentally ill, and I promised never to do it again. I apologized for telling him he needed medication. I promised I would never do that again. And he opened up and started talking to me more. And he talked to me a lot about his delusions. And I did start to use active listening and validation, not agreement, but validation. So what you're telling me is that the devil's doing X, Y, Z. Uh, so, when the door's closed, when the person's not talking, usually there's something they're angry about, and an apology can open that door.
Do you have tips for family members or for patients to, kind of bring to other providers? Because I'm assuming that, you have the ongoing relationship and you can talk to them, in your own therapeutic relationship about how LEAP works, but they see a lot of different doctors and a lot of different doctors
Yeah.
that aren't necessarily speaking with you. So do you have some tips for people to bring to other providers to kind of help them to understand, here's how to talk about this with my loved one so that you aren't going to be, making things worse and breaking your trust?
I give this advice every day with the families I'm working with. Number one, tell the provider, please don't tell my loved one they have a mental illness. Number two, please don't tell them they need an antipsychotic medication. If the medication does other things like helps with sleep, helps with depression, please emphasize that, not that it's for psychosis. Because when people have anosognosia, the whole idea of taking antipsychotic medication is horrible to them, and they don't want to do it. So those two things in particular is advice that families can give to providers. And one of the things you say is if you tell my loved one that they've got bipolar, schizophrenia, etc., they're never going to come back. You will lose them. If you could refrain or delay telling them your diagnosis, you have a better chance of keeping them in treatment.
Do you find a lot of resistance with physicians on that subject?
Yes and no. I mean, I don't know what proportions to tell you, but I've seen a lot of physicians agree. Well, part of what I do is I help families vet clinicians. So one of the vetting question is you ask the person, I'd like my son, my daughter, my relative to come see you. But how would you work with someone who doesn't understand they're ill? How would you work with somebody who has anosognosia? And if the psychiatrist or the nurse practitioner already knows about anosognosia and they've worked with patients like this, they're going to say, the correct answer is, I'm going to listen and try to build a relationship with them before I ever start recommending any medication.
I suppose that's increasingly more of a difficulty while we've had like fewer and fewer psychiatrists and other providers to choose from. But maybe that's something that we should be working on more with primary care providers as well to ensure that they can have those conversations in the atmospheres that people are feeling, like they already have a relationship with that person. That's a safe space.
Right. In the context of the collaborative care model, that's exactly what you'd hope for.
Yeah. So I've got a question from an anonymous questioner also on anosognosia. And the question is, does insight into one's thinking and mood disorder increase normally with age? And if so, has there been any research to explain this?
There's been a lot of research on whether age makes a difference, and it tends not to, unfortunately. So the short answer is I wouldn't expect it.
What kind of, do you see differences over time with people as they age with sort of how they kind of strategize and how they kind of adapt to, kind of their treatment needs over time? Or does it seem to stay relatively stable sort of regardless?
One of the things the research shows that we see over the course of a lifetime as a person ages is a reduction in positive psychotic symptoms. They actually tend to improve somewhat. But that's the main thing. In terms of the relationship to the illness, what I have seen actually is an acceptance of treatment. Like, I don't need it. I don't have any mental illness, but I've been taking this medication. I've been taking this injection, whatever. No, I'll just do it. My family wants me to do it. I don't have tension with them. And then as years go by and the person gets into their 40s, 50s, 60s, beyond, it's just become like taking vitamins for them. Even though they don't believe they're ill, even though they don't think they need the medication, they're still taking it. It's counterintuitive, but I have seen that with age and having a history of the person taking medication.
Yeah. I guess I have heard, like, sort of anecdotally from some physicians and some family members that the highs and lows of the mood element can kind of straighten
Yeah.
out with age, although like that may just be because that happens with anyone with age. That's not necessarily really I certainly am a lot less volatile than I was when I was 20.
I've calmed down after I passed 60.
So it may just be the
I'm
same
well
as what
over.
everybody goes through, but that's it is interesting, and it is something that I think is good for people to know, that it isn't necessarily that you're going to see differences in what the anosognosia is like and how it's experienced, but you might see that people have learned to cope with it over time and kind of
Mhm.
have integrated the things into their life that kind of helps, whether or not they think they need it.
Yeah. And I'm much calmer about it.
So I've got a symptom question that I think has come up many times, and I'll just give you an opportunity to answer it. Question from Shelley: how best can patients manage weight gain caused by medication? This is a big one. This comes up a lot, and it's I think a lot of people, whether they kind of recognize it or not, is one of the big reasons why we find
Yeah.
medication non-compliance and non-adherence over time.
Yeah. I mean, the obvious answer is diet and exercise. What's maybe a little bit less obvious is try to do it with your loved one. Don't encourage them to do it. Say, hey, would you like to go out for a walk with me, or a jog, even better? Or would you like to, you know, play pickleball with me? Something to engage the person in regular exercise. And then if you're doing the cooking, think about what you're cooking, and try and reduce, fatty foods, uh, I'm thinking about talking about keto, but for a keto diet can oftentimes be very effective. But diet and exercise with your engagement, your involvement, you're inviting your loved one to come with you for the exercise part. Let's go to the gym together.
And I certainly do think that it's useful to acknowledge that the weight gain is a real concern, which I
Oh
think people
yeah,
have a
it
tendency
is.
to kind of downplay it and kind of, well, don't worry about that. It's like, I mean, in a very real way, we are asking people to make sacrifices in their physical health in order to
Yeah,
have some psychiatric health. And it's helpful for people to like, I know that you're being asked to do that, and that's really unfair.
yeah, yeah. I don't minimize it, and I will say things like, if I was in your shoes, I would want to gain this weight also. I can see why you don't want to take it. But then I have an opinion that I think it's a good idea to take it.
I don't know if you've seen any research on it, but I know I certainly am hearing a lot about the increased use of medications like Ozempic to kind of
Yeah.
counter some of that stuff. Do you have any thoughts about that?
As far as I can see, I don't see a problem with using it. But I'm not a medical doctor, and I'm not a nutritionist, so I can't say with any confidence that my thought that it's a good idea
Yeah.
is a good thought. I don't know for sure, but it sure seems like it'd be a great tool.
Yeah. The fact that that's something that people are considering with people that have severe mental illness does remind me
Yeah.
of something that I always think is good to address and bring up with folks, is that, there is a tendency for doctors to neglect the physical health of this population, and just kind
Yep.
of ask them to accept things that they shouldn't accept. I mean, it's like, it
Hmm.
does matter that you're likely to, have to worry about weight gain and have to worry about metabolic issues and, pre-diabetic issues. And so like, I think it is really important to be aggressive and to ensure that people are looking after the physical health of this population.
Yep. And one of the things I've seen a lot is that there's just a low expectation. If I can keep the person calm and not agitated and not causing problems for people or the community, that's a success. That's not a success. That leads to warehousing somebody.
Yeah.
That's the beginning of heading towards possible success. So as a family member, you want to keep pushing with explicit statements about goals. I'd like to see him get out of his room and do something. I like to see her volunteer at the dog shelter and walk dogs. I like to see them get a job. Can we do better?
Yeah. I mean, I definitely think that does happen to a lot of people with severe mental illness, is that people will sort of accept that, oh, the person seems calm. That's a win. And it's just like, well, calm or overly sedated. Like, you do need,
Right.
it's very effortful to make sure that you have arrived at the correct dose, the right mix of medications. It is intended to be effortful, just like it is with other conditions that people are treated for.
Yeah. And I realize I didn't answer your question directly. Everything that I just suggested, why don't we try this with the provider? Same thing with respect to medical conditions. So diabetes, weight gain, et cetera. Are we looking at that as a family caregiver? Or if you're a consumer, if you're somebody with lived experience, ask your doctor about these things. Don't just accept it as a, you have to live with it.
And maybe that's a nice opportunity for people to have that additional conversation with their loved one about why it would be good for you to be able to also speak with their provider. Like, I can help them to, I can help you make the argument that you want them to address things that are not being addressed, that you want more active involvement in ensuring that your physical health is taken care of, that, which I have definitely had that role with my sister, to ensure that, like, hey, we want to make sure that you're as physically healthy as you can be. And if you feel uncomfortable bringing that up, I'm happy to do that. You just have to, make sure that your doctor knows that it's okay to talk to me about that. I can see that we're coming up at the end of our time here. So I'm going to wrap up, and I'm just going to remind people of our numbers and how to get in touch again. As a reminder to everyone, if you want to leave a voicemail, and I know some people prefer not to do email, if you want to leave a voicemail with your question, you can reach out to 703-294-6005 and leave a voicemail. You won't get a call back from that number, but you can leave a voicemail, and we will get that, and we'll get that onto our list of questions for Dr. Amador. And if you want to leave an email, the address is per@tac.org. And then I'll just remind everyone again of the helpline number and helpline contact form. So you can go to our website if you want to, put more information, or if you want somebody to give you a call back. You can reach out to our helpline by calling 703-951-9760. That's 703-951-9760. Or you can fill out a form on our website, and that web URL is tac.org/helpline, HELPLINE. And I encourage everyone to, if you have questions, if you want something to be addressed on the podcast, absolutely reach out, and we'll be happy to get you on our list. Thank you, Dr. Amador, for taking the time to speak with us. I know people are always very excited to be able to get some one-on-one consultation.
Well, thank you. I love these discussions, and I love getting the questions. So thank you.